Dear students, allow me to welcome you again. We are still on the tune of inflammation, and this is lecture number 6. In this lecture, we are going to discuss the chronic inflammation. By the end of this lecture, we should be able to define chronic inflammation, mention its types and possible causes, to describe the main morphological features of chronic inflammation, and to compare between acute and chronic inflammation. If you remember, in the first lecture of inflammation, we have mentioned already some few differences between acute and chronic inflammation. But now, by the end of this lecture and completion of both of the topics, we will be able to put a full comparison, including all of the features that can be differentiating between both of them. So, what is chronic inflammation? Chronic inflammation is a type of inflammation of prolonged duration, like it will stay for weeks or years, in which we have continuous process of inflammation, continuous tissue destruction and damage. In the same time, there is continuous process of healing. It's often done by fibrosis. All of these are proceeding simultaneously, or they are running in the same time, like hand in hand. So there is ongoing inflammation. The inflammation is leading to continuous tissue damage, and this tissue damage is eliciting or stimulating continuous attempts or trials of healing of the tissue. So this will lead to the dilemma of chronic inflammation. So this is a very nice illustrative diagram to show differences between acute and chronic inflammation. So in acute inflammation, usually the case is we have a stimulus or an injurious agent that elicits an inflammatory reaction, then healing attempt will occur, and this will end the stimulus or end the injurious agent, and the healing will be completed. This is the case for the acute inflammation, but for the chronic inflammation, there is a little difference. The stimulus is ongoing and continuous. So whatever the response of the immune cells to try to heal the area of the damage or the area of inflammation, this ongoing stimulus or persistent stimulus is keeping a problem of more recruitment of cells and increased inflammation. So this continuous inflammation is also happening with the continuous attempt of completion of the healing. So we have here repetitive cycles, and the disease is continuous. So we have a vicious cycle of a stimulus eliciting inflammation, starting healing, and then more of this stimulus is still going on, and so on. So it's kind of a cycle that will remain for long duration. This is why this inflammation is not easily ending or is not taking a shorter duration. It's remaining for a long time because of the nature of the stimulus or the injurious agent in this type of the inflammation. So what are the causes of chronic inflammation? We have two main tracks. Either this chronic inflammation had previously started as an acute inflammation, or it is starting as chronic inflammation from the beginning. So let's see the options if it was related to a previous acute inflammation. Maybe it is a progression from previous acute inflammation because of persistence of the injurious agent, because some injurious agents are not easy to eliminate or get rid of. They remain in the tissue and they are kind of resistant to damage. So this persistent type of injury will remain and will transform from acute and progress to chronic long-standing inflammation. The other option that sometimes we have recurrent attacks of acute inflammation on top of chronic inflammation. So sometimes we have chronic inflammatory process, but during this process we have some acute attacks in the middle. And the best example for that is a disease called the chronic cholecystitis. Cholecysto is the gallbladder, representing the gallbladder. So this is inflammation of the gallbladder, which is responsible about storing the bile that is secreted from the liver. So chronic cholecystitis is a common condition that is commonly also associated with recurrent attacks of acute inflammation on top of its chronic course. Then we have the chronic inflammation that starts from the beginning as chronic. So it can be caused if the organism from the beginning is a persistent infection, like a Mycobacterium tuberculosis, which cause TB, the disease TB that we are going to study in the granuloma. Also the Mycobacterium lepra, also it causes a disease called leprosy. We will study those in details later on. Also some viruses and fungi also can lead to chronic inflammation. Chronic inflammation also can occur in autoimmune disease. What is the meaning of autoimmune disease? Auto, like it means self. In autoimmune disease, the immune cells start to attack the own self-antigen, our body antigens. So it's an attack against the self-antigens of the body. This is why it's called autoimmune. It's like the body is hitting itself. And we have very common autoimmune diseases like rheumatoid arthritis, a very common disease, and systemic lupus erythematosus. We will study those details in their proper locations in different chapters of pathology, inshallah. Then we can see also chronic inflammation after prolonged exposure to toxic agents, like for example non-degradable material like silica. So silica is one of the toxic, let's say harmful materials that can be leading to chronic inflammatory reactions in the body after prolonged exposure, such as in occupational settings. So in certain occupations there is exposure to silica, to asbestos, and to many other injurious agents for a long time, because this is a worker who is working in a factory and he is exposed to this material every day. So this can lead to chronic inflammation also. So to sum up, the causes of acute inflammation can be related to acute inflammation, like a progression of acute inflammation and recurrent attacks of acute inflammation, or it is starting from as chronic inflammation from the start, such as in some kind of persistent or resistant infections, some cases of autoimmune diseases, and with prolonged exposure to toxic agents. So now we are ready to understand the general morphological features of chronic inflammation. If I take a section from a tissue with chronic inflammation, what I am going to see under the microscope? First of all, as this is an inflammation, we will see inflammatory cells. The inflammatory cells in the chronic inflammation are mainly macrophages, lymphocytes, and plasma cells. And sometimes we will see neutrophil. Neutrophil is mainly an acute inflammatory cell, but in some cases of chronic inflammation, we are going to see some neutrophils, and we will explain that later. Macrophages, lymphocytes, and plasma cells are called collectively mononuclear cells in reference to their nuclei, because they have only one single nucleus. And the other cells like neutrophils and eosinophils have multi-lobed nuclei. They are not multinucleated, but they have multi-lobed nuclei. So the other cells here, macrophages, lymphocytes, and the plasma cells have only one nucleus, no lobes. So we can see here in this image to our right side some dots, like small cells that are having condensed nuclei. These are mixture of mononuclear cells. The second feature of chronic inflammation is the continuous tissue destruction or necrosis. This is caused by the destructive effect of the inflammatory cells. So we can see areas of necrosis in the inflamed tissue. Then we are going to see, because this is a prolonged process, we will see some attempts of the body to heal the damage and some changes in the vessel walls. So first, let's start with the vessels. The arterioles that are around the area of inflammation will show a unique change. We will see proliferation. Proliferation means increase of fibrous tissue or fibrosis in the layer that's called the intima. The intima of the vessel is the innermost layer of the vessel. So this intima will have some fibrous tissue deposition or fibrosis. And this will lead to thickening of the vessel wall and narrowing of the lumen. So let's look here at this vessel. If this is an arteriole, we will see here that the vessel wall is so much increased, or it's enlarged because of the laying down of the fibrous tissue in the intima, and the lumen is becoming narrow. This change is called endarteritis obliterans. So it's like obliteration of the arterioles. Obliteration means like occlusion or closure or narrowing. Okay, so this is one of the features that happen with chronicity or chronic inflammation. The other change that will happen with the chronic inflammation is the proliferative change. This proliferation is happening in an attempt to heal the area because you have continuous tissue damage, persistent stimulus or injury, so the body is trying to heal. How the body will heal this damage? By three elements mainly. By new vessel formation. The new vessels are going to provide blood supply to the area of the healing. So this new vessel formation is budding or originating from the already existing vessels. They will start to send small arms or small new vessels in the area, and this process is called angiogenesis. Angio means vessel, genesis means formation. So angiogenesis is formation of new vessels in the area of the inflammation to increase the blood supply. Then we will have the main cells that will help the healing process, which is the fibroblast. The fibroblast will be proliferating and activated because they will want to lay down collagen, and this collagen will cause the fibrosis that will fill the gaps of the necrotic tissue. If we have necrotic tissue and the tissue is broken down, so the fibroblast will lay down collagen to fill those areas. So fibroblasts are going to be activated also. And in the same time, we will see the inflammatory cell infiltrate, mainly macrophages. Macrophages play very important role in tissue repair. So this cocktail of new blood vessels, fibroblast, inflammatory cells that are mainly macrophages represent the healing attempt, and this is called the granulation tissue. Granulation tissue is a preparatory tissue for the healing. When the healing is complete and the fibroblast lay down a lot of collagen, the granulation tissue it changes into fibrosis, which is completely collagenized tissue, collagen only, and all the new vessels and inflammatory cells will recede and regress. They will go back to normal. So again, let's go back to this original photo here. So if we look closely, we will see the inflammatory cells that I have mentioned before, the cells with small rounded or oval nuclei here and there. And we will see also some proliferating vessels like this one and all the small vessels here and there. And in the same time, we will see fibroblast. Fibroblasts have elongated nuclei, spindle shape. Spindle shape means they are long, like a dash. You can see them like that. So these cells that have elongated nuclei, these are fibroblasts that are being activated, and they will lay down the collagen in between. So this is a very nice representative figure for granulation tissue formation in case of chronic inflammation. Now let's mention some facts about the different cells that are sharing in the chronic inflammatory response. The macrophages, the lymphocytes, the plasma cells, and we will mention some role for eosinophil in certain types of chronic inflammation. Let's start with the macrophages. So the macrophages are phagocytes. They will phagocytose the debris or the necrotic tissues, and also the pathogen or the injurious agent. And in the same time, they will send the stimulatory signals to the lymphocytes that will also help in the chronic inflammatory reaction. So they will stimulate lymphocytes, they will eat up the organism, and they will also eat up the necrotic tissues. The macrophages, when they become activated, this happens under the effect of many substances. First of all, the bacterial products or the bacterial toxins. Those will stimulate or activate the macrophages. The next activator of the macrophages is the cytokines. Some cytokines, like interferon gamma, are going to activate the macrophages. This interferon gamma is secreted already by the T lymphocytes. So you can see here, or you can sense that there is a crosstalk or some kind of chit-chat between the macrophage and the lymphocyte. So macrophage can activate the lymphocyte, and the lymphocyte can activate the macrophage, and they go hand in hand, working together in the chronic inflammation. So the activated macrophages, in some cases, not all the conditions, they have more phagocytic activity. They become more active sometimes, and more microbicidal activity. So they have more power to kill the microbes. This is the meaning of microbicidal. So sometimes in some certain types of chronic inflammation, not all types, I am repeating this fact, in some of the types only, the macrophages will become larger with more cytoplasm. So they look more pinkish because the cytoplasm is pink in color. And their nuclei start to change from being completely blue to being some kind of faint or pale. And we can see the nucleolus inside. So this is called the vesicular nucleus. It's like it's a vesicle, yani, like it's a bubble, yani, but it's not a bubble. It's just being faint chromatin or pale in color. This appearance will start to be a little bit similar to the epithelial cells, like the squamous epithelium cells. So this macrophage, when it starts to be activated, it will mimic the epithelial cell, being with more cytoplasm, with more pale nuclei. So they will call this change epithelioid cell. Epithelioid means that the macrophage will try to look like an epithelial cell when it is active. Again, this is happening only in certain conditions, not in all cases of chronic inflammation. Sometimes also these active macrophages will join together because they want to be more powerful. So they will think, if we unite together, many cells together, we can be more powerful and we can kill more bacteria. So they will form large cells with multiple nuclei inside. Like, for example, 5 cells, 10 cells, 20 macrophages will join together. So all their nuclei will be inside one single large cell membrane. This will be called a giant cell, a big cell that is always multi-nucleated. After the macrophages are being active, they will secrete some products. These products will initiate the fibrosis and the healing attempt of the injured tissues. And later on, if this inflammation is going to subside or be resolved at some point, these macrophages will be cleared from the tissues or drained through the lymphatics to the nearby lymph nodes. So this is the story of the macrophage. Macrophage is a key player in the process of chronic inflammation. We will see some photos of these cells we are talking about in a minute. So again, let's look here. This is a nice illustration for the macrophages. So in cases of a chronic inflammation, we have extravasation of macrophages in a process similar to the leukocyte recruitment that we explained before in the acute inflammation. So they leave the blood, because in the blood they will be called monocytes. And then when they move to the tissues, they will be called macrophages. So some T cells present in the area of inflammation will secrete stimulatory cytokines like interferon gamma that will stimulate the macrophages. Also, other cytokines that are present in the area of the inflammation, they will stimulate the macrophages. So activated macrophages will do two main functions. They will share in the inflammatory response and the tissue damage by secreting many products to degrade the bacteria, but in the same time, these products will be harmful to the tissues. So they will cause tissue damage. And in the same time, the macrophage will have an important role in healing by secreting some growth factor and fibrogenic mediators that will stimulate or activate the fibroblast. This is a very nice representation of the giant cells. We agreed together that in some cases, the macrophages that are activated will unite together to form large cells with multiple nuclei inside. So this is a very nice illustration of a giant cell, a cell with a single cell membrane, single cytoplasm, but many nuclei inside. Sometimes those nuclei are haphazardly arranged in the cell. There is no certain distribution. So these will be called foreign body giant cells. This is the name. It's not all the time present in cases of foreign body penetration or presence of foreign body, but this is the name of the cell. And we have another type of giant cells where the nuclei have certain arrangement. They arrange themselves like a horseshoe appearance, or something like a C shape. Okay. This appearance is an arrangement of the nuclei near the border or near the cell membrane, like that, along the cell membrane. This is the appearance of a type of giant cell called Langerhans giant cell. So we have two main types of giant cells we will deal with during the study in this topic of inflammation and the other topic of granuloma. We have the foreign body giant cells and we have the Langerhans giant cells. Photo here is showing very nicely some of the giant cells. This is a big giant cell with arrangement of nuclei at the border. This is Langerhans type of the giant cell, this one also. And here in between we can see some of the activated macrophages that I explained before that are called the epithelioid cells here and there. They are cells with ample or large amount of cytoplasm that is pinkish in color, and they have a nucleus that is having pale chromatin and nucleolus can be seen, so it is called the vesicular nucleus. Here is one, there is another one here also, and here everywhere, here also. So this is again happening in certain conditions of chronic inflammation. Then here we have this other type of giant cell where we have again one cell with large cell membrane, one cytoplasm, but many nuclei inside, and the nuclei here are distributed haphazardly. So this is the foreign body type giant cell in the chronic inflammation. The next cell we will talk about in chronic inflammation is the lymphocyte. So the lymphocytes can be stimulated by specific immune stimuli like infections, or it can be non-immune mediated, something like trauma, something like death of tissue or infarction. This is the meaning of tissue necrosis, or death of parts of tissue in certain organs. This is the word infarction. So the lymphocytes can be activated under many different stimuli. As we said before, the lymphocytes and macrophages interact together in bidirectional way. They can activate each other, and this interaction and the crosstalk between both of them is a key important feature of chronic inflammation. Again, this is a very nice representation or illustration of crosstalk or interaction between lymphocytes and macrophages. So let's say if we have a case of inflammation, we can see let's say an antigen that is presented to the T cells, antigen from, for example, bacteria or any injurious or harmful stimulus. So this will secrete some cytokines that will activate the T cells. So T cells will become active. and then the T cells will secrete some products to recruit inflammatory cells. And these recruited inflammatory cells like macrophages will start to be activated, again under the effect of some mediators that are secreted by the T cells, so they become active, and so on. They can secrete some cytokines that keep activation of the T cells going on, and so on and so on. So the T cells and the macrophages are going in a continuous cycle of activation of each other. This is a very important feature of chronic inflammation. The next cell that is having an important role in chronic inflammation is the plasma cell. A plasma cell originates from activated B lymphocytes. When B lymphocytes become active, they transform into plasma cells and they produce antibodies. These antibodies will act or will be directed against the antigens that are present in the inflammatory site. So antigen-antibody reaction will happen. Sometimes this will fix the complement and will lead to attack or attraction by phagocytic cells or by inflammatory cells. The plasma cell is oval in shape and it has an eccentric nucleus and the perinuclear halo. Then we have certain rules for eosinophils in cases of certain chronic inflammatory conditions that are related to prolonged parasitic infections or in cases of some immune reactions mediated by immunoglobulin E, which are typically related to allergies. So these two conditions can be acute, can be chronic, and both of them, the parasitic infestation and the allergies, have predominant infiltration by eosinophils. And we have to know that the granules of the eosinophils that are eosinophilic in color, let's say, because this is why they are called eosinophils, and also it has, by the way, it has two-lobed nucleus or bilobed nucleus, as we can see here very nicely in the photo. So these granules of the eosinophil have highly charged cationic proteins. They are very toxic to parasites, and also at the same time they will lead to necrosis of the epithelial cells. So they are important to attack the enemy, but in the same time they will sometimes cause damage of our tissues itself. Neutrophils. Why neutrophils can be present in chronic inflammation? We agreed before that neutrophils are acute inflammatory cells. So do I expect to see neutrophils in chronic inflammation? Not in all the cases. Sometimes we have acute inflammation coming on top of chronic as attacks. Okay, so sometimes some of the chronic inflammatory conditions will have some extensive neutrophilic infiltrate also. And this will happen in cases, especially if we have persistent microorganisms, especially bacteria, powerful bacteria, or necrotic cells, because the neutrophils are also needed for their proteolytic activity and their phagocytic activity. So sometimes in cases of chronic inflammation, we will see neutrophilic infiltrate, and this will be called the active inflammation in this case. So activity in chronic inflammation is represented by presence of neutrophils. So again, because we don't want any confusion, neutrophils are acute or chronic inflammatory cells. They are classically acute inflammatory cells, but they can also be present in some cases of chronic inflammation that is having extensive necrosis or persistent microorganism, or as acute attacks on top of the chronic long-standing type of inflammation. Now we need to know very important fact about chronic inflammation. Before we discussed that acute inflammation has types. It is not a single type. And the types of acute inflammation were separative and non-separative. And the main distinction between both of the types was depending on presence or absence of pus. And we already discussed that in details in the previous lectures. Now we want to go to chronic inflammation. So is chronic inflammation a single type or also it has some types? The answer is chronic inflammation has also types, but this is a different type of classification. The chronic inflammation has a type that is called the non-specific and a type is called specific type. What is the meaning of specific or non-specific? Specific means that it shows certain morphological features related to certain organisms. So certain causes of chronic inflammation will cause very unique picture. This is why it is specific to certain etiology or certain cause, very specific. And some cases of chronic inflammation are non-specific, which means that it will be the same picture in all those cases. So sometimes we see very unique picture related to the cause. This is called the specific type. And sometimes we see the same picture in many diseases, which we described before, the morphological pattern of chronic inflammation, and this will be called non-specific. So as you can see here, the concept or the logic to classify the inflammation is not the same. In acute, it is related to pus. In chronic, it is related to the morphology or the appearance of the tissue. Is it unique to certain causes or not unique? This is the question to classify chronic inflammation. If there is specific chronic inflammation related to certain causes, most probably this will be called granuloma. And this granuloma is a whole big story that is going to be discussed in depth in a whole chapter. So types of chronic inflammation include non-specific and specific. The non-specific inflammation is usually following the acute inflammation, like as we said before, progression from acute inflammation that has persistent tissue damage or persistent injury and is going to continue as chronic. The good example is chronic abscess, as we said before, in the complications of abscess. The other type of chronic specific inflammation is called the granulomatous inflammation. As we said, this is a specific type. It's not happening with the usual cases of chronic inflammation. It's unique to certain causes and certain organisms. And in this type of inflammation, there is a formation of structure called granuloma. Granuloma is a term to describe the lesion that is formed in this inflammation. In this type of chronic inflammation, there is aggregation and collection of macrophages to form certain structure. It is called a granuloma because it's like small granules. And these granules can be seen even if you look at the tissue grossly, and also are seen under the microscope. So they are not scattered everywhere like the usual type of inflammation. This is unique type. When we have collection of the activated macrophages and some of the lymphocytes with these macrophages and some of the giant cells, we will have the structure called the granuloma. And here we can see, for example, this type of inflammation. So we can see here some macrophages. This is a schematic illustration showing macrophages, showing some giant cells, showing some lymphocytes. They aggregate together to form a granuloma or a small mass like a small granule. These granuloma can happen in, as we said, specific diseases, such as a disease called the tuberculosis. And this tuberculosis, the granuloma also is uniquely having central necrosis. You already finished the topic of cell injury and you knew the types of different types of necrosis. You have studied one type of necrosis called the caseous necrosis. This is a special type of necrosis that happens in the disease tuberculosis. And this caseation or caseous necrosis happens in the center of the tuberculous granuloma, the granuloma that happen in the TB. So in the middle of the collections of the inflammatory cells that happen with tuberculosis or TB as an abbreviation, we will see sometimes areas of necrosis of the caseous type. We can see also granuloma in parasitic diseases like bilharziasis. This is one of the parasitic diseases caused by bilharzia or schistosoma that you will study in depth also in parasitology. And usually they start as chronic from the beginning. This is a microscopic appearance of granuloma. We can appreciate in this image that we have collection of cells with cytoplasm that looks pink. We have a lot of pink here. This is a lot of cytoplasm. So these are activated macrophages with some lymphocytes in between. The small blue dots are lymphocytes. And then we have one large cell with peripheral arrangement of the nuclei. And it is multinucleated. So this is one giant cell. This is a very good example of granuloma. Collection of epithelioid macrophages and giant cell and some lymphocytes. And this is a very nice also high power view of the granuloma. Again, the granuloma is collection of epithelioid cells or epithelioid macrophages. The meaning of epithelioid that they are macrophages that become larger, having more cytoplasm, having a nucleus that is called vesicular. It's like having more pale chromatin, and you can see the nucleolus. Also, we can see here one giant cell having peripheral arrangement of the nuclei. And this type of giant cell is what type? What do you think? This is a foreign body giant cell or Langerhans giant cell? What is the difference? The foreign body, we said we have haphazard arrangement of nuclei inside the cytoplasm. The Langerhans giant cell, we have peripheral arrangement of nuclei. So this would be Langerhans giant cell. Again, we can see some lymphocytes in between, like this small blue dots. This is again a very good high power view of granuloma. I don't want you to worry again about granuloma. This is a whole chapter that you will study in details. We are just touching it here to mention the concept that this chronic specific inflammation has a certain structure or certain formation that is called granuloma. This is what we need to know now. This is another example of granuloma. Again, you can appreciate that it is forming something like a small mass, small structure that is rounded. And it's formed of, again, epithelioid macrophages cells with a lot of cytoplasm and some lymphocytes. Here I cannot see giant cell. It's not a must. This is an appearance of another granuloma, but you can appreciate with me that the center of the granuloma is having no details. It is kind of dead. So this is an appearance of caseation necrosis or caseous necrosis in the center of tuberculous granuloma or granuloma of tuberculosis. Again, this is for illustration later on in the chapter of granuloma. When we studied acute inflammation, we mentioned some systemic effects. Here also in the chronic inflammation, we have some systemic effects. Again, this is because of spread or release of the mediators in the circulation, and they will reach distant sites and exert some effects. So in cases of chronic inflammation, usually we can see fever, but fever that is associated with chronic inflammation is usually low grade and mild. It's usually not a high fever. If we compare that to the fever in acute inflammation, mostly the fever related to bacteria, acute bacterial infections, is a kind of a high fever. So in chronic inflammation, it will be low grade, continuous mild fever. Sometimes even it is going away sometimes, interrupted sometimes. We can also see leukocytosis because we will see infiltration of inflammatory cells. But here, because it is chronic and the main cell would be lymphocyte, so there is relative lymphocytosis. Most probably the increase in the leukocytic count will mainly be lymphocytic in origin, because we agreed before that leukocytes or the WBCs are many types. So we have neutrophils, eosinophils, we have the lymphocytes and others. So here in this type of inflammation, we mostly see lymphocytosis. Additionally, in chronic inflammation, we are going to see something we call it cachexia. Cachexia means wasting of the muscles or the tissues and weakness. Wasting means loss. We start to see loss of muscle volume, loss of some of the fatty tissue, and weakness of the body. This is caused by release of tumor necrosis factor alpha as a chemical mediator. This causes appetite suppression. So the patient has anorexia. He doesn't want to eat. But this is for a long time, not like acute inflammation. Acute inflammation is short-lived, so it's not having long time enough to make changes in the patient looks or the patient weight. But here we have long process, maybe for years. So under the effect of long-term release of chemical mediators, the patient will start to lose appetite and will start to have, again, as we said, loss of fat from the stores. So this is an example of cachexia here. If we compare this patient to that one, this is a healthy individual. If we compare here, we can see that the muscle is in this patient with chronic inflammation has much less volume, smaller muscle yani. And then we have also loss of fat from his face, and the bones of the cheek are more prominent if we compare to the normal healthy individual. So this is called the cachexia. It is not specific for chronic inflammation. It can happen with other diseases. So not any patient with cachexia is having chronic inflammation, but it's one of the effects. Also ESR, which is the erythrocyte sedimentation rate, will be elevated in all cases of chronic inflammation. Erythrocyte sedimentation rates is the rate of the sedimentation or precipitation of erythrocytes is increased because of the rouleau formation or the sticking of the RBCs together in the blood. In some of the cases of chronic inflammation, we have release of some proteins like the serum amyloid associated protein. The amyloid associated protein, this one is a protein that is secreted from the liver. Again, because this is long-term release of this protein, because it will stay for years, as we said before. This is a prolonged case of inflammation. So this amyloid associated protein, this is a protein that will be released for years. So these proteins will start to be harmful itself and will be toxic to the body. So it will start to precipitate in many organs, leading to a disease. So now the chronic inflammation has led to another disease, which is called amyloidosis. What is the meaning of amyloidosis? It is precipitation of amyloid protein. It's also related not only to precipitation of excess protein, sometimes it is related to problem in the structure of the protein. This whole disease we will study again alone in another chapter. But here, because we have to mention some facts about it because the name is here. So in the chronic inflammation, this amyloidosis is caused by the excess secretion of the amyloid associated protein under the effect of long-term chronic inflammation. Is it harmful? Yes. Is it a problem? Yes. Is it going to be damaging? Yes. It will damage many organs, especially the kidney. And we will see that in details later. So this is one of the systemic effects because it's not related to the site of the inflammation itself. It is related to the release of some proteins that will start to precipitate in excess amounts in some tissues. So now, after we completed all the facts about acute and chronic inflammation, we are now ready to compare between both of them in one of the most important comparisons in the general pathology. The items of comparison are many. One of them, the first one, is the onset, the start. What about the start of the disease in acute inflammation? Is it a rapid start or a gradual start? It is a rapid or immediate start. And the chronic inflammation has a gradual start or gradual onset. It starts over some time. So Acute inflammation has sudden or immediate onset, and the chronic inflammation has a gradual onset. What about the duration of the disease? Which one is short-lived? Which one is a long process? Acute inflammation is of short duration. Short means that maximum it will stay for days. Chronic inflammation can be staying up to months or even years. So it's having a duration. Next, the vascular phenomena. What are the vascular changes in acute inflammation, and what are the vascular changes or the vascular reactions in chronic inflammation? The vascular phenomena in acute inflammation represented by vascular dilatation, increased vascular permeability is very prominent in acute inflammation. It's very important in the reaction. In chronic inflammation, we didn't say much about the vascular phenomena. We didn't mention any vascular dilatation or increased permeability. It was mainly the thing that we said is actually obliteration of the vessels. And also we said that we have some new vessel formation. So the vascular phenomena represented in vasodilatation, increased permeability is very prominent in the acute and much less prominent in chronic inflammation. What about the nature of the inflammatory reaction? Which one has more exudates, more fluid? Which one has more proliferation of cells? The acute inflammation is characterized by more fluid exudate or more cell proliferation? More fluid exudate. Why? Actually, it is related to the vascular phenomena, because in the vessels, when they are dilated and when the vessels have increased permeability, we have more fluid, right? It makes sense. So we have exudates, which mean inflammatory cells with the fluid, with the proteins. But in chronic inflammation, we mentioned that it is mainly proliferative disease. It has inflammatory cell proliferation, vascular proliferation, fibroblastic proliferation. Of course, we all know that proliferation means increase in number, right? So this is the idea about the inflammatory reaction or the type of inflammation. Then what about the signs of inflammation? Local signs of inflammation, which mean redness, hotness, swelling, all of those. And keep in mind that those signs of inflammation again are related also, most of them, to the vascular phenomena. So which one has prominent local signs of inflammation? Which one has less prominent or minimal signs of inflammation? Agree that acute inflammation has prominent signs of inflammation that are, as we said, redness, hotness, swelling. This is related to vessels, vascular phenomena. But chronic inflammation, as it doesn't have a lot of vascular phenomena, so the signs of inflammation are subtle or little or minimal. The toxemia in acute versus chronic inflammation. Toxemia, still this term we are going to explore in the next lecture. It means the toxic manifestations in the body. In the acute inflammation, we have acute toxic manifestations, right? But in the chronic, we have chronic toxemic effect. And this chronic toxemic effect can show many changes, such as, for example, the amyloidosis that we said, because we have increased persistent production of excess amyloid proteins that will lead to deposition in tissues and the chronic toxic effect. Okay, so toxemia here does not mean bacterial toxin itself. It means we can say the systemic harmful effects. Let's go to microscopic features. What are the predominant cells in acute inflammation and what are the predominant cells in chronic? In acute inflammation, the main predominant cells are neutrophils. And after like 1 or 2 days, we have infiltrates by macrophages. In chronic inflammation, we said the predominant cells are the mononuclear cells altogether, which are lymphocytes, plasma cells, macrophages, and giant cells. What about the blood vessels, the appearance in the acute inflammation? In acute inflammation, the blood vessels are dilated and thin-walled. While in chronic inflammations, they have what we call it endarteritis obliterans, which means thick wall and narrow lumen. They are not dilated at all. Why we have this thick wall? Because of fibrosis in the intima of the vessel. What about the presence of fibrosis? Which one of them has fibrosis? The chronic inflammation, right? Because in acute inflammation, we didn't mention any fibroblastic activity in the inflammation itself. It may occur later on after healing, but not during the inflammation. But with chronic inflammation, we have fibrosis going hand in hand with inflammation. This is a part of the disease. Microscopic features of both of them. Let's go to changes in the parenchymatous organs. Parenchymatous organs are like, let's say, the solid organs like the liver, like the kidney. What we are going to see in the neighboring tissues, are they going to be affected or not? Usually in acute inflammation, we will have some kind of reversible cell injury in the neighboring tissues. So the most common type or basic type of cell injury will be cloudy swelling. Right? So we can see this cloudy swelling in the surrounding tissues of acute inflammation. While in chronic inflammation, the main change we are going to see in parenchymatous organs, like especially the kidney, the disease called amyloidosis that we mentioned in many locations. So those two manifestations, cloudy swelling, amyloidosis, are options of changes that can happen in the different parenchymatous organ in the tissue in relation to acute or chronic inflammation. Now we are left only with the fate of inflammation. I think the fate of acute inflammation we already explored before. We have four different fates. It can have a resolution, complete restoration of normal tissue. We can see healing and repair by fibrosis. We can see progression and spread of infection. We can see also transformation or a change into chronic disease. What about the chronic inflammation fate? Do we have options or we don't have any option? Actually, chronic inflammation usually results in one fate, fibrosis. We don't have option of resolution. In chronic inflammation, it will not ever go back to normal. And also we don't have the same type of spread of infection in similar to acute inflammation. So it's mainly fibrosis. This is the main fate in chronic inflammation. So this is the complete comparison between acute and the chronic inflammation. It's very important cornerstone in the topic. So you need to take some time and try to absorb this comparison and understand the concepts behind those differences. So next we will go to our activity zone before we end the lecture. So our activity this time is going to be different. It's like to test yourself. It's like an assignment you can do. It doesn't have any mark and you don't have to deliver it to anyone. But I would like you to grab a paper and to put this empty table of the comparison and write down the features of comparison like onset, duration, vascular phenomena, etc. And after you study the comparison, try to write it in your own words and try to remember it. Write it from your own mind. You don't have to copy paste, obviously, because this is not a test, any real test. It's just a self-assessment. And after that, you will see where are your points of defects and where are the points that you didn't understand. And I hope that you can let me know if your feedback about it. And I already in the first lecture, I have put out my email in the first slide. So you can communicate with me through email at any time and let me know if still there is anything that is not clear, or if it was clear and you want to give me a feedback also. I will really appreciate your any type of feedback from you. It will be very constructive. So I hope that you do this self-assessment and I hope that it will benefit you. With that, I would like to thank you very, very much for listening to the lecture and your bearing with us through these recorded lectures, and now we are only left with single lecture in the topic of inflammation, which is going to be related to the bacterial infections of the blood. Thank you very much.